Nu kommer vi här. Välkomna till dagens St Görans föreläsning. We have the pleasure of greeting Bernard Carroll from Ann Arbor, Michigan, and who's going to talk about new diagnostic tools in psychiatry. And I think you have seen from the invitation that Bernard had his education in psychiatry in Australia, and then came to US about 10 years ago. Has had a solid scientific education in pharmacology, and I guess it has been very useful, and those of us who don't have that may envy you. We have to learn it the hard way. I think your research has given new hope, because to the personnel treating the patients on the ward, taking all the blood samples, maybe for, I don't know if it's the first time, but at least we know that this may be very helpful in the diagnostics, which is then helpful in the treatment of different subgroups of depression and maybe other psychiatric diseases. You have been here in Stockholm a couple of days, taken part in symposium on steroid regulation or hormone, the steroid hormone of the brain, and of course that's a big field, and you are world famous for the father of the dexamethasone test. Can we say so? And of course, it is extremely popular right now. I don't know if it will survive or how it will progress, but we will let you tell us about how it started and the state of the affair right now. And I know you have lots of unpublished data, so we are very eager to learn more. And welcome. And then after we will have a discussion here, and then informal discussion upstairs.
Thank you. Well, thank you, Lennart, and let me say that I am honored to give this St Görans lecture in psychiatry. I just hope that I can do justice to the people who have given it before me. Lennart asked me to talk about diagnosis in psychiatry and about the application of laboratory procedures to assist clinicians in making psychiatric diagnoses. And I think the title that you gave was something like The New Biology of Psychiatric Diagnoses. Was it? I think what we are doing actually as psychiatric clinical investigators is to a large extent not so much developing new biology, but finding new applications for established biology to assist us in our work with patients in the psychiatric units. And just to put the record straight, it was really Grant Little, who was an endocrinologist, who introduced the dexamethasone suppression test. And that was done in the context of clinical medicine. What we and other people have done subsequently has been to take that test, make some modifications to it, and then apply it for answering psychiatric diagnostic questions. But I certainly wouldn't want to take credit for developing the dexamethasone suppression test in its own right. I guess when we begin to talk about psychiatric diagnoses, the clinicians among you immediately recognize that although people think they know how to diagnose patients with psychiatric disorders, most of us still recognize the need for a good deal of humility, and most of us still recognize that frequently we are uncertain about the correct diagnosis of individual cases. and that we would like to have some assistance from the laboratory to improve the certainty or the confidence or the reliability of the diagnoses that we make. And those of you who are familiar with the comparative studies that have been done in a formal way, comparing diagnostic practice in different hospitals, in different cities or in different countries, are very much aware of the quite wide discrepancies in diagnostic practice that have been identified. So it's because of these problems that have been with us for a long time, of reliability and also validity of psychiatric diagnoses, that we would like to have some assistance from the laboratory, just as physicians in other areas of medicine and surgery have developed laboratory diagnostic tests. In the United States, the emphasis to try and resolve the issues of diagnostic uncertainty, the emphasis has been to develop strict diagnostic criterion checklists, exemplified by the Spitzer research diagnostic criteria, or the St. Louis diagnostic criteria, the so-called Feiner criteria. And these introductions and new classifications, particularly for depression, have their uses, but they suffer from a problem of validity. It is possible to demonstrate very high reliability with the use of these diagnostic checklists. The question is, are the diagnostic categories generated by these checklists the same as clinicians have been used to recognizing in their clinical work with patients? Or do they relate to any biologic disturbance that can be identified in the different groups of patients? And I'll say a little more with some of our own data about this. In the case of depression, there has been a very long debate going back to the time of Kraepelin 100 years ago about whether clinical depressions are one entity with a spectrum of presentations, or whether there are two fundamental classes of depressed patients. Patients with reactive or neurotic or characterologic depressions, essentially with a psychological underpinning and explanation, as against patients with biological or endogenous or autonomous depressions for whom somatic kinds of treatment are probably appropriate. And the best way to summarize that general problem is to say that nobody can agree about how many kinds of depression there are, what classifications of depression are the most appropriate ones to use. And that disagreement has serious implications for the management of patients, because you will find individual psychiatrists or other mental health workers having quite polar disagreements about the ways in which a given patient should be managed, depending on their theoretical orientation and the diagnostic formulation that they come up with. And the reason for that is that, of course, although it's possible to identify a prototypical case of melancholia and a prototypical case of neurotic or reactive depression, most of the patients that we treat, unfortunately for them and for us, contain a blending or a mixture of features reminiscent of both types. And that's why the uncertainty frequently develops. So we would like to have some laboratory procedures to help us. And I think it's possible to say at the present, if I could have the first slide on, please, that the research in biological psychiatry, particularly in the field of depression, has given us now some advances that really are promising. The most promising I've listed here on the board, and you can see that from various functional directions, from neuroendocrinology, from the study of sleep electroencephalography, and also from the study of psychomotor functions, there are several promising developments which will assist clinicians in making the diagnosis of melancholic or endogenous or biologic depressions. Now, I don't have time to talk about all of these this afternoon. I'm going to focus on this first one, which is where we have done most of our work. Let me simply mention that I believe within the next 2 years or so, it will be possible, with a combination of these three approaches, to obtain positive laboratory identification of virtually all patients with melancholic illness, which will be of great assistance in distinguishing them from other types of dysphoric or depressive patients. To go on to the dexamethasone suppression test, I won't spend time today talking about the background, the development, and the early history of this test. I'll show you this slide simply to outline in a very sketchy way the reasons for using a neuroendocrine approach in the investigation of psychiatric patients. Basically, it comes from the fact that limbic system in the brain serves a number of functions. Regulation of endocrine control is one function, and of course regulation of behavior and affective states and emotional states is another important function of the limbic system. Since we cannot have direct invasive studies of limbic system function in human patients, we can at least exploit this common overlap of functions in disturbed individuals in order to obtain indirect information about the integrity of limbic system areas, for example, in patients with depression. That is the basic logic of the neuroendocrine strategy. It was developed in the late 1960s, and I think it has now reached the point where it is giving us information not only of theoretical interest, but of use to the practicing clinician as well. The aspect of this test that we have, the aspect of this neuroendocrine strategy that we have worked with primarily has been the dexamethasone suppression test. That is what DST stands for here. And just to give you the conclusion at the beginning, this test now appears to be giving us information that indicates that it is a state-dependent and specific biological marker of the melancholic or endogenous type depressions. Now, what is the dexamethasone suppression test? How do you do it? It's a test of neuroendocrine control mechanisms whereby, I'm going to skip over this. It's a test of neuroendocrine control mechanisms whereby a dose of synthetic steroid, dexamethasone, is given to the patient in the overnight version of the test at about 11 o'clock at night. Here. The following day, blood samples can be drawn to measure the plasma cortisol concentration. In a normal individual, or in a psychiatric patient without melancholia, or in a recovered melancholic patient, all the plasma cortisol concentrations on this day following dexamethasone will be suppressed. And that suppression will be maintained for a complete 24-hour period. So that if we see elevated cortisol concentrations at 8 in the morning, or 4 in the afternoon, or 11 o'clock at night, then we can say with some confidence, as I'll show you, that this patient certainly has disinhibited neuroendocrine function, which indicates disinhibition of activity in the limbic system, and that this is specifically related to endogenous depression. So that is the general outline of procedure for the test. There have been some refinements recently in our standardization of it, which I'll come to in a little while, but this is the prototypical version. And this version was developed, I should say, on the basis of much more extensive studies where we had inserted venous catheters and sampled for 48 hours from patients receiving the test. And from the results of those studies, we've been able to abbreviate the test so that this relatively simple version can be used on psychiatric units. Now, if you do the test as I've described it in a large number of patients, and here I'm showing the results from 215 of our patients with endogenous depression, and then 150 some patients with other psychiatric disorders. And if we examine the cortisol results, say, at 4 o'clock in the afternoon following dexamethasone administration, the pooled results, these are from inpatients as well as outpatients, and they also are the results using different doses of dexamethasone, which is an issue that I'll come to shortly. But the pooled results give you an overall impression of what you can expect to find on a psychiatric unit. You see, firstly, a bimodal distribution of the overall results, with the plasma cortisol concentration expressed on a logarithmic scale here on the bottom axis. And this is the number of patients in each interval frequency. The patients who are not melancholic have their cortisol values distributed in a unimodal fashion with an upper limit effectively of about 5 microgram per deciliter. Virtually all the patients in this second mode are patients diagnosed as melancholic, so that if a high value is found, with high confidence, this signifies the presence of melancholia rather than another psychiatric disorder. Again, as you can see, a good number of patients who are diagnosed clinically as melancholic have apparently normal suppression. So that with the pooled results that I've shown you here, about 45 to 50% of melancholic patients will have abnormal dexamethasone test results. We can do better than that with some modifications of the test, as I'll show you shortly. Before we go into our recent data, I want to spend a few minutes just defining some terms for you. In developing laboratory tests, we use a number of modified Bayesian concepts. Sensitivity is one, and sensitivity essentially means what is the true positive rate of the test. How many people with the disease that you're interested in will have a positive or abnormal test result? That is sensitivity. And that mathematical expression here simply signifies the true positive cases divided by all of the diseased people, that is true positives plus false negatives. So if you're looking for a good laboratory test, you want one that has good sensitivity. In addition, you require that a useful test should have good specificity. And specificity really is the true negative rate. How many individuals with diseases other than the one that you are interested in will have a normal or a negative test result? And again, you can have that expression here, the true negatives divided by all the non-diseased people, that is the true negatives plus the false positives. Going a further step, you can then say, how frequently is a positive test result true positive for the condition that you wish to diagnose? That is, what is the diagnostic confidence or the predictive value of an abnormal test result? And that is expressed simply as the number of true positives divided by all the positive tests, true positives plus false positives. If we have time at the end of this talk, I will go into this conditional probability theory a little more to talk about the way in which the usefulness of a test can be influenced by the prevalence of the condition in the population being tested. Sensitivity rates and specificity rates are independent of the prevalence. But this, which is the most useful performance figure for the clinician is heavily dependent on the prevalence of the condition in the population. And maybe I'll show you some examples if we have time at the end of the talk. Well, now, since we described our early studies with this 4 or 5 years ago, a large number of other centers have begun to study this dexamethasone suppression test. This slide summarizes the results from 9 studies. I won't go through them all in detail. There are some American, there's an Italian study. This is a study from Munich that was reported recently in the Lancet, a study from Leningrad, some other studies that I've become aware of recently, one from Gothenburg, which again has very consistent results. And you'll see that with a very large number of patients studied, well over 1,000 patients among all these 9 series, overall, about 45% of patients diagnosed as either primary or endogenous depressive, because different classification systems, though largely overlapping, were used in the different centers. About 45% of patients with the index diagnosis of depression had abnormal test results. Quite a range in the sensitivity figures, almost certainly due to variations in the test procedure. And I think we can overcome that now with the standardization that we've developed. Much more importantly, a great consistency in the specificity, with an average figure of 96% specificity among these 500 patients tested across the different centers. So just to summarize that here, 9 studies, a large number of patients with about a 50% prevalence rate overall, the average sensitivity and specificity, and then the diagnostic confidence associated with an abnormal test result. Now, those are really very encouraging figures, particularly, I think, the replications from one center to another. One doesn't always see that in psychiatry, but this time I think we have it. The reasons for the variation in sensitivity, I think, are due to this fact here, that the test procedure was not standardized. The dose of dexamethasone varied from 1/2 to 2 milligrams in different studies. The plasma cortisol criterion level for judging whether a test result was normal or not ranged actually from 4 to 7 microgram per deciliter. And the timing of blood samples varied quite a lot among the different studies as well. Some people drew a sample only at 8 o'clock in the morning, others only at 4 o'clock in the afternoon, others drew 3 samples, as I showed you on the earlier slide. So we have put a great deal of effort on our own unit over the last 6 years into standardizing the test so that the optimal performance could be determined, and then people in different centers can obtain truly comparable results. And we would say now that, without presenting all of our standardization evidence in detail, I'll simply summarize it here. The optimal dose is 1 milligram rather than 2. These 2 blood samples taken together give you the best diagnostic information with the greatest economy, and the plasma cortisol criterion value should be 5 microgram per deciliter. Now, using those parameters for the test, our current performance figures with it are as follows. Let me just go on from here. Our current performance figures are that 2/3 of the patients are detected by the test. The specificity, as you see, has not suffered at all in lowering the dose from 2 milligram to 1 milligram. The specificity is quite high, and so the diagnostic confidence is as well. So that's a very encouraging figure. It's considerably better than the 45% or so that we were obtaining with our earlier procedure with 2 milligrams. Just to go back to the slide I skipped over, here is the reason why we say that both the 4 p.m. and 11 p.m. samples should be drawn. At 8 in the morning, only 1/4 of the abnormal test results are detected by that sample. 4 in the afternoon, 78%, 71% at 11 at night, and combining these two together, that is either one abnormal, 98% of the positive tests are detected. So for practical purposes, you can ignore the 8 o'clock time, because anything that is abnormal then will also be detected by the later samples. Okay. Now, just to give you a comparison of this performance as a diagnostic test against some of the other things that are already standard in widespread use in internal medicine. If you take the situation where a person is rushed to a coronary intensive care unit with severe chest pain, and the question is, does this man have a myocardial infarction or not? One of the laboratory tests done will be a serum transaminase value, and 55 units is a reasonably conservative criterion level to choose. You see that about 3/4 of the patients will be identified by that test who have indeed had a myocardial infarction. It isn't very specific, and the diagnostic confidence is reasonable but not particularly high. Similarly, the new radioimmunoassay for acid phosphatase activity in early carcinoma of the prostate. About 60% of patients are detected with high specificity and therefore with good diagnostic confidence. And then the figures for the current protocol with the dexamethasone test, as you see, compare very favorably to these other laboratory tests that already are widely used and which no physician really would want to be without. Note also that physicians use diagnostic tests and make judgments from them, even though the diagnostic confidence is not absolute, which brings me back to a very important general point. That is, any diagnosis in medicine or in psychiatry, when you come right down to it, is nothing more than a probability estimate. And you will have a range of confidence surrounding the diagnoses that you assign to individual patients. That is, diagnoses are not things that are fixed forever, and they are always subject to new interpretations and new developments with the patients. Just to illustrate the clinical utility of the dexamethasone test, we have studied a great number of outpatients as well as inpatients on our clinical unit. It's important to study outpatients because most depressives are in fact diagnosed and treated and managed as outpatients. Most depressives never reach inpatient status clinically. So that if a test is to be truly useful, it should be able to identify outpatients with melancholia as well as inpatients. And here you see with the 1 milligram dose, 57% of inpatients, 49% of outpatients had abnormal test results. This is based on only a single blood sample at 4 in the afternoon, because for practical reasons, that's the protocol that we used with our outpatient studies. We can draw 3 blood samples from inpatients, but these outpatients were going about their normal business and came to the hospital to have a blood sample drawn at 4 o'clock in the afternoon. So it's a very practical test that outpatients can easily manage, and you see there's no statistically significant difference in the sensitivity obtained with melancholic outpatients compared with inpatients. Here are the corresponding results with the 2 milligram dose of dexamethasone, and you see there the great effect of dexamethasone dose on the sensitivity obtained, and that is the reason why we now recommend a dose of 1 milligram rather than 2 milligram for the general use of the test. Another very important clinical point I must stress, but I cannot spend a lot of time on, is this, that there are certain medical conditions or certain drug intake conditions which will render a test invalid in individual patients. I simply want to show this slide. We've discussed them in our publications, and anyone who uses the test should go and carefully look at them, but I don't have time right now to discuss the reasons for these various technical exclusion criteria. But they are listed in the publications that we have published and that are coming out in the near future. But do remember this, because you cannot expect to have a good experience with the use of this test if you are contaminating the sample with patients that will give you invalid test results. Well, what can we say about the validity of this as a diagnostic procedure for melancholia or for endogenous depression? I think there are several lines of evidence which converge and which point to the fact that this probably does have good validity for diagnostic application. We can talk first about face validity, and that comes from the figures you've seen already, the high specificity and the high diagnostic confidence associated with abnormal test results. Face validity comes as well from our finding that there is a probability gradient associated with the certainty of the clinical diagnosis of melancholia. And here are the results from one of our outpatient studies where we have the frequency of abnormal results plotted here against the diagnostic probability. Patients who were not melancholic, that is neurotic or reactive depressives, a 2% frequency of abnormal response. Patients considered melancholic by the clinicians who met research diagnostic criteria for probable endogenous depression, a 21% frequency, and patients who were considered melancholic by the clinicians and who met the definite research diagnostic criteria, a 50% frequency. And this is about what you would expect for the association with the certainty of the clinical diagnosis. Another type of validity is predictive validity, and what we would like to be able to say is, does the finding of an abnormal dexamethasone test result predict treatment outcome, or does it predict long-term course? On the matter of treatment outcome, I'll say very little today. There are a number of studies underway. There have been some preliminary reports, although they disagree among themselves, about whether an abnormal test result predicts specific responses to one class of antidepressant versus another class of antidepressant. And that, of course, would take you back into some of the neurochemical theories about the disease itself, norepinephrine versus serotonin deficiencies and so forth. But the data from the clinical studies in correlation with the neuroendocrine findings so far are too preliminary for any really definite statement, and really a lot more work needs to be done on that question. On the second question, however, we have very good data now from 2 or 3 studies, namely that if a patient has been treated, appears to have recovered, and treatment is then discontinued, but his endocrine test result has not returned to normal, then he is at serious risk for early relapse. That comes from some studies. Originally, when I was in Australia, we noticed this pattern. Another study from our own unit done with John Greedon, and a third study done by Ivan Goldberg in New York within the last 12 months. All of them agreeing on this point here, that there is predictive validity for relapse in patients. And that, of course, means that there may be another application of the test, not only for initial diagnosis and classification, but also to tell the doctor, how long should I continue treating this patient? Do I need to continue antidepressants for another month, or is it safe to stop? And if these early reports are confirmed, then I would say that we will be able to use this test to assist the treating physician in monitoring the outcome of treatment, knowing when to discontinue, that is, identifying when the depressive episode really has resolved. Another possible use of the test, and another predictive use, is in assessing the clinical response to ECT. This is a complicated slide, and I'll just point out 1 or 2 things from it. These are 6 patients having a course of ECT Here are the dexamethasone test results in the top panel, abnormal to begin with, and mostly coming back to normal values early during a course of treatment. On the bottom panel are the Hamilton Severity Rating Scores, quite severe at the beginning, some mild improvement after 4 to 6 treatments, during which time the test results have normalized, and then at the end of a course of treatment, some further improvement in the severity ratings and further improvement in the neuroendocrine response. This patient made an incomplete recovery, and her neuroendocrine response failed to normalize during a course of ECT. And so we might be able to say from these data, which have been replicated as well by Max Fink's group now in New York, that possibly if we look at patients who are not improving at the end of 6 to 8 or 10 treatments, if their endocrine values haven't returned to normal, then it may be unlikely that they ever will respond to a further session with ECT. That's another potential use of the test. Finally, in terms of validation of the test, we could say that construct validity comes from these various lines of evidence here. With complete recovery, it does return to normal. In bipolar patients, it is normal during the manic phase and is abnormal really only during the depressive phase. If patients are tested serially during treatment, one sees a gradual improvement of the results. There's an association with family history, an association with suicide, and again, coming back to the fundamental neuroendocrine strategy, what this test is telling us is this patient has disturbed function in the limbic system, which is where we believe the primary pathology of melancholia resides. A couple of examples of these points. Here you see a patient receiving a course of ECT with abnormal tests early in the course of treatment, coming back into a borderline range of results, and then completely normal tests in association with the clinical improvement, as you see there. So you see it's a stable phenomenon, gradually resolving as the illness resolves. Other studies that we have done looking at patients whose depression was anticipated, we've been able to see that the neuroendocrine disturbance may precede the clinical manifestations of the depression, sometimes by as much as several weeks before the subjective or behavioral features of the illness actually appear. Again, just to illustrate, this is a bipolar patient studied in the depressed phase, in a transitional phase from mania to depression, and there are the results during mania. You see how normal they are, and then she goes into a depression, and you see the gradual appearance of the elevated cortisol values here. That's been a consistent finding from several centers now with the bipolar subjects. And very briefly, the association that we have found with suicide among our patients, here are the results from 5 patients who did complete suicide, all with melancholic diagnoses, who had abnormal test results, either during that episode or in a prior episode during which we had studied them. A further 11 patients with very grave suicide attempts, again, all with abnormal test results, remote from the suicide attempt. That 100% figure here should be compared with the average 45-50% figure over the past 6 years using the various modifications of the test that I talked about before. So there appears to be an association of suicidal potential with this abnormality in melancholic patients. But again, as you see at the bottom, people with other diagnoses who have completed suicides did not have abnormal test results. So this again speaks to the specificity of the test for the melancholic condition. Well, coming out of all of that, we would say that you can then think about using this as a laboratory marker for diagnostic and classification purposes. And you would make a prediction, that, namely, that if you have different ways of classifying depressed patients, then you could use this endocrine marker as an external validating criterion for your nosology, and that the validity and certainly the homogeneity of a clinical diagnostic category of depressed patients would be related to the frequency of abnormal test results that you see in that category. Well, if we use that as a prediction, let us look at some of the ways in which this actually works out. Here is an outpatient study that we did with the 1 milligram dose, 4 p.m. blood sample, a total of 89 depressed patients. That is, heterogeneous group of depressed patients. Of those 89, 47 were given the diagnosis melancholia by the clinicians, and they met RDC criteria as well. And 19 of them, that is 40%, had an abnormal test result. Of the same 89 patients, no fewer than 72 met the research diagnostic criteria of Spitzer for major depressive disorder. That is, so we've got 25 extra patients. But from the figures here, only one extra abnormal dexamethasone test result among those 25 extra patients, with consequently a lower frequency of abnormality, that is a lower sensitivity here. So that is telling us that the category major depressive disorder is considerably more heterogeneous than the category melancholia. And that should therefore be a signal, certainly to research groups, that this category is probably not an ideal one to use for strict classifications of subjects in research. And similarly, looking at the St. Louis variation, that is primary major depressive disorder, a very similar problem. 15 extra patients and only one additional abnormal test result among those extra patients. So again, the heterogeneity of results. So that's one way in which, as I say, you can use now this laboratory marker as an external validating criterion for diagnosis. Another use of it can be to help clarify the relationship among various conditions that may be related to each other, but where there is at least a lack of agreement. Here are the results now mixing the inpatient and outpatient data. Firstly, for normal controls, 4%. That seems to be the background frequency of disturbance in the general population with this test protocol. So you have to remember that. Is non-endogenous depression a categorically distinct entity from melancholia? Well, by these figures, it certainly is. There is a very low frequency in non-endogenous, that is neurotic or reactive depressives, compared with the bipolar and unipolar depressed patients who appear to be no different from each other. Okay? And here is then a group of other psychiatric patients with somewhat elevated frequency, but by no means up to this level here. What about mania and mixed manic depressive states and some other conditions? Here again is the reference value for non-patients. Mania and hypomania, we're finding about a 15% frequency of disturbance. The reason for that, I believe, is that mixed in with these manics and hypomanics are some of these. That is, patients with the Kraepelinian mixed state, with mixed dysphoric and activated features, who appear no different from the typical bipolar depressives with respect to the frequency of this neuroendocrine disturbance. Another important condition, schizoaffective disorder, with arguments going back many years. Is this a clinical variant of melancholia? Is it a clinical variant of schizophrenia? Is it a separate condition? Well, by these criteria, it appears to be a variant of melancholia, which is consistent with the conclusions of many other investigators recently, and which is consistent also with the results from the sleep EEG studies by David Kupfer's group. Finally, there's this interesting group of patients here who I've labeled borderline personality. Really, what they were patients with a severe depression, but with very confusing characterologic features as well, so that there was great disagreement among the clinicians as to the correct diagnosis. These are patients with acute depressions. Was this a non-endogenous? Was it an endogenous depression? By structured interviews, they met endogenous criteria mostly, but there was great unreliability in the clinical assessments, precisely the sort of patient for which a laboratory diagnostic test would be helpful. And again, you see in these a high frequency of abnormality, suggesting that these were patients who did indeed have a melancholic illness, which was masked, in this case masked by the associated character disorder and neurotic features. So that's another, if you will, clinical variant of melancholia that we can get some assistance at identifying, and in consequence, I hope, at treating more effectively by the use of these laboratory procedures. Again, in relation to these subjects, recent studies with the sleep EEG give entirely consistent results. That is, they have sleep EEG disturbances no different from patients with typical melancholia. So here is a way in which these laboratory markers can assist us with some of these very confusing individual cases. Well, let me just finish up by summarizing what I think could be the uses of this test. If you accept the evidence for its validity and specificity, then it can be used for initial diagnosis and classification of individual patients. And as you saw, that can be done at diagnostic confidence levels that are fully comparable to the diagnostic confidence attached to other laboratory tests used in internal medicine. It can be used to help resolve some long-standing nosologic issues, such as the relationship of schizoaffective disorder, for example, to manic depressive illness, with some particularly difficult groups of melancholic patients, patients presenting with catatonia, several studies now indicating that this test is useful for identifying affective catatonics and separating them from schizophrenic catatonics. For adolescents, where the typical melancholic presentation is clouded by developmental features that are typical for adolescents, the test has proved to be useful there, and even sometimes with younger children. In geriatric patients and in neurological patients, for example, who have suffered from cerebral vascular accidents with a consequent mood disorder, where the patients have difficulty communicating, or in the differentiation of pseudo-dementia from true dementia. This is another obvious area of clinical application, and I think Dr. Wetterberry has some results with that. For monitoring treatment and for helping to decide when active antidepressant treatment may be discontinued, for predicting relapse, and eventually maybe for selecting specific drugs for this subgroup of patients with abnormal neuroendocrine function. A final use, which is really a research use, but which I think is terribly important, can be for helping investigators from different centers to compare their own work. That is, if you find that a group in Australia finds a 10% frequency of disturbance with this test, whereas a group in New York finds an 85% frequency, then even though both groups believe that they are using the same operational clinical diagnostic criteria, then it is absolutely certain that they indeed are not studying comparable groups of patients. So that is one way of assessing the diagnostic consistency between different centers. Similarly, if one group, like the Munich report that recently has come out, suggests that patients that they diagnose as non-endogenous have a significant frequency of abnormal test results, then without prejudging who's right and who's wrong, at the very least this can serve to signal that the diagnostic practice in Munich is different from what it is in the other centers. And so what I think we are moving towards now is, by a series of successive approximations, that is, refining the clinical criteria, using the laboratory tests and matching one against the other, particularly as many centers now begin to get experience with the test, we will gradually arrive at a new definition of melancholia that will include these laboratory disturbances and give them appropriate weighting along with the traditional clinical features, so that then we can get very homogeneous groups of patients that will allow us to answer much more satisfactorily than we have been able to so far many remaining questions in the affective disorders, like indications for specific drugs, like relationship between drug plasma levels and clinical response, and so forth. Because many of the studies of these other issues, genetic questions as well, many of the studies of these other issues, I think, have been contaminated by the fact that using clinical criteria alone, it has not been possible to get a really homogeneous group of melancholic patients for study. But now I think we will be in a much stronger position. And as I say, with the use of the three markers that I mentioned, within the next couple of years, we should have positive laboratory identification of about 90–95% of melancholic subjects. Thank you.
Whether it be that they are not ill enough, or whether they would have been positive if you had studied them on another day at another time, or whether they are actually another illness. What's your idea of that?
Well, I'm glad you asked that, because that's a very important issue that still remains. It isn't just a matter of severity, and I think the best evidence for that is the comparison of our outpatient data with the inpatient data. Outpatients had much milder illnesses, but still a very high frequency of disturbance. So it's not just a question of severity, as the Munich group has suggested recently. It may be that there is fundamental heterogeneity amongst the people that clinically we call melancholic. And if so, then this test can help us to identify that heterogeneity. That's one possibility. From studies of the test-retest reliability, we have found some cases who initially appeared to have normal test results and then converted to normal at some later point in the illness. Which brings me to what I think is the real reason for the fact that about 30-odd% have normal test results. Namely, that what we are being told by this test is simply an indirect signal about disturbance in the limbic system. Because it is indirect, we may not see it in all cases, but the cases with normal test results may indeed have the same disorder. It's just that, that we're not getting this signal. So in effect, if you go back to the endocrine strategy, we have a limbic system that controls behavior and controls endocrine function. In the primary behavioral disturbance, we are seeing, if you will, a noise phenomenon expressed through the neuroendocrine system. That may be the significance of this disturbance. So I think it certainly is worth repeating the test if you have a strong suspicion that this is a melancholic disorder. But I don't think we have good data yet to say that these are clearly different subgroups of depressive illness. What we need to do, I think, is to look now at all of the three measures that I mentioned in combination and look at what is the overlap. And if we see different patterns emerging there, maybe that will be additional evidence for true heterogeneity among them. But my own guess is that it is fundamentally a homogeneous group, and that what we have is a weak marker, relatively speaking, rather than fundamentally a heterogeneous group.
You have not looked at the hypothalamic hormones. I mean, if it's on higher levels of detected in this group, where you have a weak test parameter, as you said. Have you studied that? The releasing factors?
Well, the releasing factor for this system, corticotropin releasing factor, unfortunately is not yet identified. For luteinizing hormone and for prolactin control and for somatostatin and so forth, some of the other hypothalamic releasing hormones are identified, but the corticotropin releasing factor is not, so that we don't yet have in our hands that tool to explore the functional status of the pituitary adrenal axis at the higher level. So that's really why we're still measuring cortisol and just beginning now to measure the pituitary ACTH responses. Okay.
The outcome of the DST test may be related to any specific part of the melancholic syndrome, like severe retardation.
I think not. Judging by the patients that we've seen and the wide range of clinical presentations that we've seen in patients, highly agitated people, severely retarded people, people with neither. There appears, so far as we know at present, no good specific association with clinical features. There's a suggestion that if you take a cluster of the typical physiologic symptoms, sleep, appetite, weight, sexual appetite disturbance, and so forth, that as a group there is some correlation with the endocrine disturbance, but it's not particularly striking.
Johan? A practical question. If you want to follow the response of treatment, how often can you do this?
The biologic half-life of dexamethasone is about 50 hours. The plasma half-life is about 4 to 5 hours. But the functional half-life is about 50 hours for suppression of the pituitary adrenal axis, so that you really shouldn't repeat the test any more frequently than at least every 5 days, I would say. And we generally go at least a week between repeating the test. That way I think you will get reliable results the second and the third and the fourth time that you do it, and you will avoid carryover effects from the previous dose of dexamethasone.
In the survey of various methods useful for the biological diagnosis. You did not mention Schildkraut's co-workers. Their experiments with
MHPG.
amine metabolites in the urine.
Yeah.
Do you have any experience with those?
Well, the reason for not mentioning their work is this, number 5. That as Leo Hollister has pointed out, the values for urinary MHPG described by Schildkraut and Maas and others fall squarely within the range of normal values, so that they may possibly be useful for discriminating subgroups of depressives, bipolar versus unipolar, for example. But it would really be the first time in the history of medicine that a normal test result was used to